Lee Shu, Duke DA, Chief Bill. Hello and welcome to Rear Admiral Chris Buchanan, Rear Admiral Francis Frazier, and Dr. Matt Nanook, CDC, and Dr. David Fitter, CDC, and all of our tribal leaders, attendees, and other participants. My name is Bill Smith, Acting Chairman of the National Health Board, as well as the Alaska Area Representative and a board member of the Valdez Native Tribe. It is my pleasure to welcome you to this IHS and CDC vaccination information session. The purpose of this session is to allow both IHS and CDC a chance to explain the draft vaccination plan that they are now published, and to give Indian country the opportunity to ask questions about IHS and the state plans. We have heard from many tribes that you do not have enough information to choose the jurisdictions you would prefer to work with, and we're hopeful that this information sessions will support your decision making. We know that your questions and comments will help IHS and CDC understand where the draft plans are lacking in details and where they can be adjusted to be improved. We also want to note that the deadline given to the tribes to make this jurisdiction selections, which is today, was not made by the Indian Health Service or the CDC. The deadlines come from HHS and Operation Warp Speed. The National Health Board, along with the national and regulatory regional partners organizations, have submitted a letter to Secretary Azar to protest the deadline and give the extension for tribes. Tribal concerns and recommendations on the deadlines are going to be best directed to HHS and Operation Warp Speed. We encourage all of you to send those comments to consultation@hhs.gov. In a moment, I'll be turning the floor over to Rear Admiral Chris Buchanan to provide opening remarks and an introduction to the IHS staff that are joining him for this session. After these opening remarks, Rear Admiral Francis Frazier will provide a short presentation. After that, they will turn the floor over to their colleagues at CDC for a short presentation and updates on the state plan procedures. After that, we'll open the floor to questions from our online audience. To ask a question, please type your name, title, and tribe into the chat box, and the National Health Board staff will unmute you so that you can speak. We are using this process to keep the sound clear. And now, to provide us with opening remarks, it is my pleasure to introduce Rear Admiral Chris Buchanan, Deputy Director of the Indian Health Service. Rear Admiral, are you there? Hello, Rear Admiral Chris Buchanan, are you there?
Sir, can you hear me?
Yes. Yes, we can. Welcome.
Thank you, sir. Good afternoon. I'm happy to join you for this important meeting. Thank you all for attending today's informational call. Smith and the NIHB board for the great work you do in your leadership throughout the COVID-19 pandemic, and for hosting this call today. At the Indian Health Service, seeing something.
Rear Admiral Buchanan, apologies for interrupting you, but we can't hear you. It may be that you are too far away from your computer.
How about now? Can you hear me?
Yes, yes, we can. Thank you.
All right, I'll start over if that's helpful. Good afternoon. Happy to join the meeting. I want to thank Chief Smith and the NIHB board for their great work, all that you do and your leadership throughout the COVID-19 pandemic, and for hosting this call today. At the Indian Health Service, we value our partnerships with tribes, tribal organizations, and urban Indian organizations, and remain committed to sharing information and support of American Indians and Alaska Native people we serve. The IHS is participating in regular meetings with the HHS agencies and communicating with Operation Warp Speed as they develop a vaccine distribution plan that aims to deliver a safe, effective vaccine for COVID-19. In early September, we formed the COVID-19 Vaccine Task Force to lead the agency's COVID-19 vaccine activities. We recently released the IHS COVID-19 Pandemic Vaccine Draft Plan that was developed by the task force with input from recent tribal consultations, urban confers, and listening sessions. This plan will help to ensure that a COVID-19 vaccine is effectively delivered to American Indians and Alaska Native communities that depend on our strong partnerships between the federal government, tribes, urban Indian organizations. The IHS initiated tribal consultation and urban confer on the draft plan with a comment period that closed last week. We're reviewing all comments and will update the plan as appropriate, and want to thank you all for your comments. These will be used to inform the final IHS plan. At the time of release, the draft plan was based on the most current information available to IHS. IHS continues to issue important vaccine-related updates. Recently, the IHS released planning documents to assist areas as well as local IHS tribal and urban Indian health programs with their COVID-19 vaccine planning efforts. We want to be prepared and gather information now so we are ready when vaccines are available for distribution. While we did receive tremendous response from tribes, there are many tribes with Indian healthcare facilities who have not shared their decision yet. We understand there is confusion out there, and with the rapid pace of vaccine planning and distribution activities, we also know there are several questions and concerns about the IHS draft plan and other federal guidance. And we hope the session today will help address some of your questions and concerns. Yesterday, IHS released a Dear Tribal and Urban Indian Organization leader letter to provide clarification on vaccinations of non-beneficiaries. The task force received several questions from tribal consultation, urban confer, and IHS area directors on the authority to provide non-beneficiaries with COVID-19 vaccines coordinated through IHS. We continue to work with Operation Warp Speed and other federal agencies to develop an effective plan to prepare for the deployment of COVID-19 vaccine. Again, we are committed to ensuring COVID-19 vaccine is effectively delivered to American Indians and Alaska Native communities. As always, we appreciate your time. We look forward to today's discussion about the draft plan. I'll now turn it over to Admiral Francis Frazier, the Director of Office of Public Health Support, who is the lead for the IHS Vaccine Task Force. Thank you.
Rear Admiral Frazier, are you able to speak are you unmuted?
Can you hear me now?
Yes, we can.
Okay, great. Is that, am I sounding too loud or just about right, or?
I think your sound is just fine, and we can all see your slides as well.
Thank you so much. I appreciate that. And thank you for the opportunity to talk today. I also have two colleagues, the Deputy Vaccine Task Force leads, that is Commander Kaylee Fretland and Commander Holly Van Loo, who are also called in to the presentation. So they also have a portion of this presentation to present. So I just wanted to let you know that, and for logistical purposes, I know they're both on the line. But thank you for this opportunity again. And if we could go ahead and advance the next slide, we'll just jump right into content and get started here. Thank you very much. And hopefully you can see this all clearly. And I wanted to put this timeline up here because I feel time has been such a critical factor for all of us who've been involved in COVID-19 vaccine planning, you know, across the system, across the country, quite frankly. So I just want to hit a few key highlights with this, and I hope this is helpful just to sort of put things in perspective as far as the timeline, especially related to Indian Health Service activity. On September 4th, a couple of highlights I just want to make here. IHS established a vaccine task force through our incident command structure for IHS, realizing the importance of vaccine distribution and allocation activities. On September 16th, CDC issued the interim playbook for jurisdiction operations. On September 24th, HHS initiated tribal consultation on COVID-19 vaccine planning for Indian country. As you all recall, there were 6 consultation sessions held from September 28th through October 1st. On September 25th, IHS initiated Urban Confer on COVID-19 vaccine planning for Indian country. And on October 1st, our IHS pre-planning tool was sent out to the areas for distribution to gather estimates on populations. On October 9th, the deadline for tribal consultation and Urban Confer was established, and then the Indian Health Service initiated tribal consultation and Urban Confer on our pandemic vaccine draft plan. Those comments were for a 7-day period, and the deadline for those was October 21st. So again, very rapid turnaround for a lot of activities, and I think this graph this slide just displays that. If we could go on to the next slide, please. Tribal consultation and Urban Confer on September 24th. You know, as I said, the HHS initiated tribal consultation. IHS participated in the NIHB information session on October 25th, and again, those 6 regional consultations. And as I stated, you know, we initiated Urban Confer and participated in a listening session hosted by the National Council on Urban Indian Health on October 8th. The tribal consultation and Urban Confer written comments were due October 9th. On October 14th, IHS initiated tribal consultation and Urban Confer on the draft plan. And as I said before, it was due on the 21st. A lot of activity, a lot of input that we've been provided. If we can go to the next slide, please. Thank you. So based on the feedback received from consultation and confer activities, we reviewed all questions, comments, and recommendations, and we identified major themes. So when you look at the column on the left-hand side, these major comments, these were the major sort of categories that were received from HHS consultation. Under vaccine distribution, allocation and prioritization, there were specific requests, information requests on the IHS distribution process, including coordination across areas, service units, and tribes, inclusion of emergency management, ordering points of distribution. Tribes also recommended that they should be able to determine their priority groups and number estimates, including for tribal and non-tribal members, for vaccine allocations and for vaccine allocations. Tribes want the ability to work with their federal and state and local at local levels to receive the vaccine. So these were sort of these major comments under that category. Under guidance, representatives also asked for more guidance on enrolling as a vaccine provider and also for choosing IHS. Specific recommendations were made on the CDC playbook and that review of IHS guidance, that we need to more IHS guidance and activities are needed and recommended. And there was also recommendations about consultation on the playbook when it becomes available. Under data reporting and management, more information was requested about the data surveillance systems and the vaccine reporting requirements, both for the state and for IHS. And there were questions related to clarification on the reporting requirements and the systems that are planned on being used. Under vaccine storage, representatives expressed concerns about vaccine wastage and asked for more information about the vaccine storage requirements, including the use of dry ice, the availability of dry ice distribution, if equipment purchase is advised, availability of instructions, specifications and training were other topics that were brought up. Under communications, comments included that communications should be modifiable to the local level, and that there's a need for easy to read and culturally relevant information. Under tribal consultation comments, there were comments on the need for more tribal engagement in vaccine planning. IHS has reviewed all the written comments and we have summarized those comments that we've received from HHS and from the IHS consultations and urban confers. When you look at the right-hand column, this was more related to the IHS comment period for our draft plan. And the comments really centered around the composition of those, those categories of our 6 teams, distribution and allocation, data management and prioritization, communications, vaccine administration and safety and monitoring. So what we're doing is we are currently reviewing all these comments that we have received, and we're updating the respective sections of the draft plan as appropriate. We've also received other comments on the composition of the vaccine task force and also on tribal consultation. So right now, the task force is still reviewing these comments, and we're working diligently to incorporate those comments into the draft plan, and we will be issuing a tribal consultation and urban confer summary report on these activities. If we could go to the next slide. Thank you. As you know, I just wanted to hit a few key points here. As you are aware, the IHS pandemic vaccine plan was developed using that CDC jurisdiction interim playbook as guidance. We did release it on the 14th and kept it available for comment through the 21st. We did hear back from a lot of federal partners, tribal and urban leaders, as well as the CDC on the draft plan. We will need to clarify some additional information that as we're modifying the plan. We need to consult with CDC on these activities, and we need to make sure that we're really addressing all of the questions that were shared during consultation. We are anticipating that we will release our final plan next week. We go to the next slide, please. And so again, for our pandemic vaccine plan, the structure will remain the same, really based on the CDC playbook guidance. And we'll stick to that because I think that's consistency is the key, especially with these rapid turnarounds. Now, what I'd like to do is turn over we're going to have Commander Kaylee Fretland give updates on a couple of these sections, and then she will turn it over to Commander Holly Van Loo to provide additional updates on the remaining sections of the draft pandemic vaccine plan. So Commander Fretland, are you available, or can you do a radio check with you?
Yes, sir, I'm on. Can you hear me okay?
Yes, I can hear you good. Is she coming in loud and clear for everyone else?
Yes, she is.
Very good. Over to you, Kayla.
Thank you, Admiral Fraser. Go ahead to the next slide, please. So what Commander Holly Van Loo and I are going to take you through is the different sections and some of the updates, and we're going to discuss the updates that we are working through right now, sharing more information that we have available, and that will be in the final plan. So in section 1, we talked about vaccine availability, and it's really important to recognize that we broke this up into a pre-planning, which is what we're actually in right now, and then phase 1, phase 2, and phase 3. Phase 1, we know there is going to be limited doses of vaccine, and then phase 2, we're going to roll into a more larger number of doses of vaccine, and then phase 3 is really rolling this into a continued vaccination strategy. So in our pre-planning phase, in our draft plan, there wasn't, in all these phases, we did have a lot of information detailed out in the draft plan because there were still things that were being finalized. So I'm happy to share with you now that most of these have been finalized. And I think it's really important as we look at this timeline that Admiral Fraser talked about, why it's so important to get many of these things accomplished in this pre-planning phase to really position Indian Health Service to be able to have vaccine on day 1, to be ready to receive vaccine on day 1 when it's available. So the first thing is the program agreements, and I'm going to talk about those in a few slides here. So I'm not going to go into many details about these, but all of the CDC has created a provider agreement. All the states have gotten a program provider agreement that they have sent out to the vaccinators and the programs within their state. CDC has taken that same agreement and structured that a very similar agreement, and there's going to be 3 of those for IHS. So there's going to be an IHS and CDC memorandum of agreement, a CDC and tribal government agreement, and a CDC and urban Indian organization agreement. That agreement, once IHS is going to be coordinating the collection of those agreements, once we have those agreements, that's going to start the onboarding process for vaccine ordering. Centrally, IHS is going to be doing the vaccine, put this information into what's called VTRACS, or Vaccine Tracking System. And I may show you an image of that on the next, how that workflow happens on the next slide. At the site level, Operation Warp Speed is developing an Oracle portal for end user access. This means at your site, you are going to have a vaccine coordinator or point of contact who is going to be entering in orders at your site. So that Oracle access needs to happen. The other access that needs to happen right now in our pre-planning or information is the documentation portion of the requirements that CDC is requiring for COVID vaccination. So if your site is an EHR RPMS user, or if it's a COS user, there's going to need to be capability that Commander Van Loo is going to talk about in our data management section that's going to need to be addressed and assessed and identified if that is a capable platform to be able to send the required vaccination administration data. The other access we need to ensure that sites have is access to the Vaccine Administration Management System, otherwise known as VAMS. We are taking the population totals, the information that was filled out in the pre-planning tool, to identify as a whole our agency's critical and target populations and our total patient population, or population that we estimate that we are going to be vaccinating. They are using this to inform their planning at a national level for allocation. So when we look at all the jurisdictions, all the federal agencies, they're collecting all of our population estimate information, and that's going to determine an overall allocation strategy for the entire US. And that's really going to be a percentage breakdown, our percentage versus all the rest of the other jurisdictions. We're also doing phase 1 planning for both ultra cold and frozen. So we've heard a lot about ultra cold. In this, there's a lot of logistics with ultra cold. Pfizer's had some recent calls with the awardees, and I'm guessing many of you or points of contact have possibly seen some of that information that's come out. But phase 1 planning for ultra cold is going to be really critical, that we identify whether it's through a hub and spoke model, central locations, and we're going to be working with the area offices to help us with that planning for those areas. And lastly, we have education for provider training. That did come up in a lot of the consultations. CDC and HHS are going to be putting out additional training, specifically CDC. And once the vaccines, Pfizer and Moderna and the manufacturers are also going to have additional training specific to their vaccines that are going to be available once we know what vaccines are coming out. So as those trainings become available, they will go on to our website at ihs.gov/coronavirus/vaccine. So phase 1, I talked about this a little bit, but we're working on, when we get into phase 1, that's going to be three scenarios. It's going to be ultra cold, it's going to be frozen, and there's the potential mixed scenario for a mix of ultra cold and frozen. We do not know, and no one knows yet, which vaccine will be available first, because we don't know which vaccine is going to have the EUA, the emergency use authorization. However, the one thing we do know is we do know that there is going to be a limited supply initially, and then that will grow gradually. So ordering during phase 1 is actually going to happen at a centralized location. And this is very common for most of the jurisdictions, but for phase 1, because of the limited amount of vaccine, the ordering is going to happen at the NSSC level and then be allocated to our sites within our distribution. So the sites that are going with IHS for distribution. And I'm hoping everyone can still see the slide. Mine just blinked a little bit at me. As we move into phase 2, that ordering is going to be at the local level, so through that Oracle platform that we're building. So backing up to the centralized ordering, because I know this is a question that has come up on many of the tribal consultations. What we're focusing on with guidance from CDC is the healthcare personnel as the first wave of critical and target populations to receive vaccinations. We recognize at a tribal entity and tribal government level that you may choose other critical and target populations, and that is your ability to prioritize who you need to vaccinate first. But at an agency level, we will follow CDC, ACIP guidance, and if it's healthcare personnel as the first target population, that'll be how the allocation strategy happens and that will mean that everyone will get an allocation based on a percentage for their healthcare personnel to cover that. We know that our goal, Operations Warp Speed's goal and CDC's goal, is to have everyone vaccinated and have the ability to have everyone vaccinated for those who want to be vaccinated throughout this vaccination campaign. So in phase 2, as we transition to the local sites, the ordering is going to be through the Oracle portal. And then this phase will further prioritize our next set of critical and target populations. And once we move into phase 3, the demand for the vaccine will likely be significantly reduced as we will have a wide availability of vaccine to order from, and there will not be a shortage, hopefully, of vaccine. Go ahead to the next slide. All right, our section 2 of our plan is prioritization, and I'm sharing with you the estimated population that we have received from the pre-planning tool estimates that each of you worked on, provided to your area offices, and the area offices provided to the vaccine task force. So overall, as an agency, we are estimating about 55,000 healthcare personnel, and this includes direct and non-direct, as well as EMS. We are estimating over 132,000 essential workers, and we gave some examples of what essential workers are, but we hope as tribes you determined who your essential workers are. But this generally will include law enforcement, transportation, teachers, likely tribal government employees. Residents in tribal long-term care was close to 2,500. Elders, The population estimates that we received was about 423,000. Those at high risk for COVID-like illnesses was just over 1 million. And our total estimated population, beneficiaries, non-beneficiaries, employees that were reported was over 1.7 million. What we're doing with these numbers, and they are still being finalized, we're still reaching out to sites, we're still confirming some of the ones that were blank and reaching out to the area of point of context to help us identify those, is we're taking and mapping these. We're looking at both storage locations, healthcare personnel estimates, population estimates. We're going to be working with the area offices to look at sites within a closer proximity to each other. Again, looking back at that hub and spoke model. We do know, actually I'll move and talk about that in distribution. The last thing that the prioritization team is looking at is a healthcare provider survey for vaccine acceptance. And I think this has come up quite a bit, that there is a lot of vaccine hesitancy. And so determining how that's going to impact uptake at your sites, I think that's important to know from a local site and local tribal government standpoint, is what the vaccine acceptance is. It's also going to help us target some of our communication strategies. Go ahead to the next slide, please. Section 3, distribution and ordering. So this is a big part, is the pre-planning tool to help us catalog distribution source preference. Is it IHS? Is it state? We had about a mix, about 50% are still undecided or had left blank. And so we're hoping today's session and some of the information we can provide is going to help you with that decision making. Once the vaccination program agreements are released, the distribution team is going to be responsible for collecting those agreements and then getting them to CDC. Because once again, IHS is really the coordinator in this process. The agreements are between CDC and the tribal government and CDC and the urban Indian organization. As far as coordinating vaccine ordering, what's going to happen, and I talked about that just a little bit above, but we are going to get an allocation amount from CDC. And we will know, I'm just going to use an example. IHS, you have 100,000 vaccines to use. How are we going to allocate those? If that is our first allocation, how are we going to allocate those? So NSSC and distribution team are going to be looking at the percentages, and we're going to start with our critical population, so healthcare personnel. And we're going to base that on percentages provided. That's broken down by area. And again, we have to look at if it's ultra cold, that comes in a minimum of 975 doses. And so how can we utilize hub and spoke models? How can we centralize some of that for the partnerships? We know that we are going to be able to transfer vaccine. So there's going to be a transfer or redistribution process. So if there is a centralized hub and spoke model for ultra cold, that we will have a process in place that that vaccine will be transferred to you. We also know that the vaccine is stable for 5 days in the fridge if it's ultra cold. So that does enhance the ability to transfer that vaccine. Coordinating the distribution of vaccine to facilities. So McKesson and the manufacturer are going to ship to the end user. So once that order is applied, whether it's applied at a central location or at the site level, it's still going to be distributed to the end user unless it's a hub and spoke, as we work with the areas if that is the best model for those facilities and that those tribal governments and tribal organizations. And again, that's going to be an allocation percentage. I know in our draft plan we used calculator, and really what we were referring to is a percentage. I know in tribal consultation that the user pop came up as a not accurate way to do percentages, which is why we really relied on collecting information from the pre-planning tool in different categories so we could assure that this was an equitable percentage that was reported to us from you. Ultimately, it's going to be full allocation. We want to ensure that all sites are getting full allocation to vaccinate their population. As we move through the allocation strategy or allocation calculators, it'll be healthcare personnel. So we have 55,000 anticipated healthcare personnel. And I'm using that number as an example. That may not be the final number. But if we have 55,000 healthcare personnel, that means that we want to get out 110,000 doses. And we know then at IHS that we have fully allocated enough vaccine to our federal, tribal, and urban programs and facilities to vaccinate what they responded back as their healthcare personnel population. We do know that we probably won't have 100% vaccine uptake, and we know that you may further prioritize some target or critical populations within your population, and that's okay. But once we get to that 110 or whatever that first target population allocation is, then we'll move into the next allocation percentage because they're not equivalent as we go across. So kind of back to that user pop, we're not using user pop as our one defined percentage of how we're breaking down vaccine. We'll also be coordinating that phase 1 planning. So I think we've talked about this. The ultra cold vaccine is likely to be the earliest vaccine, followed by the frozen vaccine, which may be also available early in phase 1. There's a lot of logistics with ultra cold, and so ensuring that we are ready for those. It's not going to be NSSC at a centralized location is not purchasing ultra cold freezers, but we are looking at the gloves needed. Can we give out recommendations on the special gloves for the ultra cold vaccine for the handling? The data loggers that'll need to be managed to be able to continue to monitor the temperature for ultra cold vaccine. Dry ice, ensuring that we've identified the dry ice, and we've been assured by Operation Warp Speed that there's no dry ice shortages. They are tracking all dry ice and are able to identify how much dry ice is available. Go ahead to the next slide. Okay, so we do recognize that one of the biggest questions is how is IHS distribution different than state distribution? So we've developed some of these tools, and I think this was shared earlier through the area directors. I'm not sure if it fully made it down to all the tribes, but it had been a tool that we wanted to get out and to share. So looking at state distribution versus IHS distribution. From a state, the state's going to utilize their immunization program. We're utilizing our existing NSSC distribution structure. We're utilizing the Oracle web portal that's being developed by Operation Warp Speed. States have existing portals, their immunization information systems, that will continue to be used. For IHS, the order is going to be reviewed by NSSC, same at the state. So once a site puts in their vaccine order, it's reviewed at the state. And then both are going to be submitted into VTRACs for orders. Both state and IHS distribution are going to have vaccines shipped directly from McKesson or the manufacturer to the end user site. So I think as you look at this, there's not very many key differences. It's just the portal that's being used to really order the vaccine. But essentially the process is the same. They're still reviewed by a centralized body or someone, and then sent to VTRACs and McKesson and the manufacturer. Go ahead to the next slide. And this just really visualizes what I just had told you. I just wanted to be able to visualize and see that we're both feeding information into VTRACs, which is then going to submit the information to McKesson and the manufacturer for ordering purposes. Go ahead to the next slide, please. Okay, I mentioned program agreements earlier when I was talking about Section 1, vaccine availability. The program agreements are working their way, going to be working their way through HHS clearance to get to you. But I did want to point out just some differences. So the states have one CDC COVID-19 program provider agreement. This has been sent out to most of the vaccine programs within the state. Once enrolled, those programs will have access to order, receive, and administer COVID-19 vaccine. So CDC is the coordinator for the IHS distributed COVID-19 vaccine. So CDC has developed 3 program provider agreements. There's a CDC and tribal government or tribal organization agreement. There's a CDC and urban Indian organization agreement. And then there's a CDC and IHS MOA for direct service facilities. That MOA will be signed by Rear Admiral Wiaki on behalf of all direct service healthcare facilities. For federal healthcare facilities, once they are enrolled or once that MOA has been signed, there's still a Section B that the tribal and urban programs have that the federal facilities will also be required to fill out, but that will be sent separately. And again, like the state, once they're enrolled, the programs will have access to order, receive, and administer COVID-19 vaccine. So you see how these key pieces are starting to be put into the system, and it mimics similar programs or similar processes of what the state is also doing. Go ahead to the next slide, please. All right, I'm going to turn the rest of the sections over to Commander Holly Van Leeuw. Thank you.
Okay. Good afternoon, everyone. Thank you so much for joining us today. I'm going to put on my video just so I can share with you myself here. So thanks for joining us today. This part here, the section 4 vaccine administration, is something that's near and dear to me. I am the vaccine coordinator for VFC and for all vaccine on campus at my facility. So I'm the individual who's typically receiving, coordinating mass vaccination events, administering vaccine. I would tell you every Wednesday the last several weeks I've been administering many vaccines. We've been doing hundreds of vaccinations per day for influenza. And so this section, vaccine administration, is near and dear to me because oftentimes I'm the one eventually giving the vaccine and planning these events. So it's really critical that when we host these events for COVID vaccine, that our providers are well trained. So we want to make sure that each site that is receiving vaccine has that point of contact defined, which we've received through our pre-planning tool. And we'll ensure that that provider has information about vaccine storage and handling, which will be really critical. Some of these vaccines are quite fragile. We'll also want to make sure that we provide guidance on preparation, administration. There will be videos, handouts, one-pagers, all kinds of things that will be rolling out to every site, specifically directly to the point of contact at each facility. And then also making sure that the appropriate documentation is available, such as the fact sheet, if the vaccine is available under an emergency use authorization by the FDA, or if the vaccine is fully licensed, that would include the vaccine information statement. So some of the things to consider is that this will be unlike anything we've seen before, perhaps similar to H1N1, but nonetheless, we will have a number of doses eventually with a great need to cover our population. So we may need to think outside the box as far as traditional vaccinators and engage perhaps non-traditional vaccinators, perhaps EMS staff, dentists, pharmacy technicians, utilizing our pharmacists, nursing providers, nurse collaboratives to really make sure that we can staff these events. But more importantly, and most importantly, would be the support staff, because there will be a lot of extra duties to do when we're at a vaccination event, including registration of the individuals, paperwork, consent, things like that. For staffing vaccination events, we would estimate that approximately each vaccination would take about 7 minutes, and I would say that's pretty accurate with what we've been doing with mass vaccination events lately. You could schedule as much as every 10 minutes if desired, or every 5 minutes if desired. But estimating, how many staff members will you need, especially when we receive these ultra cold vaccines very early on. If we have 975 doses of ultra cold vaccine that has to be used within 5 days at refrigerated temperature, well, that really puts us in a crunch. So how do we determine how many vaccinators do we need, and also making sure we have that ancillary or support staff to do all the other components? Because quite honestly, giving the vaccine alone is not that much time or effort, but it would certainly be all the other components. And answering questions, I think, is going to be really critical with this vaccine. So this could be used as an estimate to guide you in your decision for staffing. Next slide, please. So coordination events, what will those look like? Our vaccine administration team is working to create as many tools as possible to assist your facilities, your tribes and urban programs with creation of vaccine event checklists that can assist you. For the early phases, which would be the closed pods, meeting is by invitation only. And this would be focusing on your priority populations, whether that's your healthcare providers, your elders, whatever that is. trying to think through how will we contact these individuals? How will we schedule them? When can we invite them in? And what is that time frame if we have ultra cold vaccine versus if we have frozen vaccine, and the limitations and stability components of each of those vaccines. Later phases, when we have more vaccine available, we'll probably look more at the mass vaccination event planning, which would be something where it's not so limited in who can get vaccination. It wouldn't be just focused on priority groups, but we would still need to adhere to social distancing. You could invite maybe a drive-by or drive-up clinic, a walk-up event. Would you consider using that indoors or outdoors? Might be a nice option in certain areas of the country. Not so much in others where it may be very cold this winter. So thinking about all those components and utilizing some of the checklist and things that we've already created and hope to roll out anytime, we're hoping that all of these resources can be placed on the webpage, the COVID vaccine webpage at ihs.gov. The other thing we need to consider when we're planning these vaccine events is planning not only for that first dose, that first flurry of activity, but ensuring while they are there that we are scheduling that second dose appointment for them to return, and staffing the event, preparing for preparations for supplies, things like that. The other thing to consider is there's some national level discussion about whether the manufacturer would hold back, or Operation Warp Speed would hold back that second dose and then release it to you upon that second dose event when it's due in that 21 day time period, or 28 days, depending on the brand. And as a reminder, each vaccination would be brand specific. So the first dose you get, you would need to get the second dose of the same brand according to the manufacturer's recommendations on that timing and spacing. Next slide, please. Communications are going to be key. We're working diligently to create some mechanisms for communication and hope to utilize any resources you've created. So at this point, we have the COVID vaccine website. We will update as much information on there. We have a framework that we're planning to utilize. If you come up with any amazing resources, we would love to hear about those. We've already found some amazing resources that Indian Country is creating. So here we hope to have the plan, sample planning resources, the vaccine safety information, videos, training, educational resources, things like that, as well as your points of contact. So you know who to reach out to in the case that you have questions. Also, HHS and CDC are going to be working along with our other federal partners to make sure that we're doing education, focus groups, all kinds of things that we need to engage now and soon at a community level to make sure that we get, we can handle the components of vaccine hesitancy and answer some of the questions. Also, internal and external communications. Next slide, please. Data management, we have some workflows to look through. We have, again, the state versus IHS distribution. For state, you will go through your typical, I think these are switched. These are switched. Apologies, we will fix that and correct this. So it really should be on the left-hand side would be IHS distribution, depending on your EHR, RPMS status, whether you use EHR or RPMS or not. It'll be really critical to engage your IT staff to make sure that the electronic updates are completed so that you can transmit your data through one pathway that's been identified. And we'll show a graphic on that in one moment. Alternatively, if you choose to go through the state distribution, you would upload information to the state IIS or use any alternate process as defined by that state. IIS is the state database for vaccinations. Next slide, please. Here is one graphic for the patient data flow. And again, we will make these slides available to ensure that you can review these in your own time with essentially plenty of time to help make these decisions. So this is just graphically representing some of the information I just described that it will go through IHS and then go to the CDC for data flow. Next slide, please. This slide is a little crazy, but it really is pointing out that if you're an IHS direct provider or you're a tribal or urban site and you have an electronic health record and you want your data to flow through IHS to the CDC, you can do that. You'll need to make sure that your electronic health records are up to date with the patches. If you choose not to use that pathway, there is an alternate strategy, and that's the CDC platform called VAMS, the Vaccine Administration Management System. It is a web-based program that you can use to document an administration of vaccination, call patients back for second visits, do scheduling. There are a lot of different capabilities with VAMS. Next slide, please. And lastly, we have the safety and monitoring section. We assure you that this is really critical, and we have a terrific team leading this. We plan to do a systematic approach to vaccine adverse event reporting, including VAERS, which I think we mentioned earlier today, which is a passive system whereby which someone could go in and report an adverse event, whether that's a patient, a clinician, or whatnot. There's also an active monitoring system that we have in place that we've been using for remdesivir and dexamethasone, where we have sentinel sites across the country where we're having data reported to us on a weekly or every other week basis so that we can gauge if there are any opportunities for internal review, if we find a safety signal that's concerning, and then reporting that data out to all the sites to make sure you have familiarity with what's going on, what may have been noted across Indian country before perhaps it gets some of the data gets reviewed and sent back to us from VAERS. So the safety and monitoring group is made up mostly of our national pharmacy and therapeutics group, including the pharmacovigilance team. And they also have a website, a lot of educational activities and information to make sure that we are doing safety and monitoring. And they're doing a ton of training as well. Next slide, please. This is the example of the hub and spoke model, whereby each sentinel site will report data on, that they may note at their site about adverse reactions and report that to a central IHS National Pharmacy and Therapeutics Committee staff for us to do that active surveillance. Next slide, please. And I'll turn it over to Admiral Fraser for next steps.
Very good. Thank you so much, Commander Van Loo and Commander Fretland. Appreciate the information. As you all can see, I'll be quick, just for time's sake. As you can see, a lot of work has gone on with the IHS plan, and we're currently in the midst of incorporating consultation and confer comments into the plan. We're working to meet the November 6th deadline for the Indian Health Service to submit that plan to CDC. We are my recommendation is to connect with your area point of contact and your site vaccine point of contact to begin looking at assessments and planning. And it'd be good to review the pre-planning, the checklist we set out with the pre-planning information regarding the draft plan. Looking at your local priority populations and really appreciate, as you can see, we have very knowledgeable staff working on these activities, thinking about those ultra cold vaccines and the pre-planning associated with that product and thinking about how to conduct vaccination events. If we go to the next slide. And as was previously mentioned, we are really, if you go to the IHS website for COVID-19. We're posting information on there. We did post information about beneficiaries and non-beneficiaries for ITU on there, where we got frequently asked questions, and we'll be continuously updating this, clearing information and getting it posted for your consumption and to answer your questions. And with that, I will turn it back over to NIHB and CDC. Thank you. Over.
Thank you for your presentations. Now we'll take questions. Please type your name, your title, and the tribe in the chat, and the National Indian Health Board will unmute you, and that you can provide your comments and your questions.
Chief Bill, this is Carolyn Hornbuckle from the National Indian Health Board. We did get some questions in the chat, so I will go ahead and read those out while we unmute some of the other folks that have some questions for us, if that's okay with you.
Thank you, Carolyn. Yes, it is.
Okay, so I'm going to just move up a little bit here. So first off, we got some questions about the slides and the presentation. Just to let everyone know, this presentation is being recorded. We will be posting this on the NIHB website, and we will also be posting the slides there and links so that folks know where to go to review the materials that IHS just shared with us. We also got some specific questions around the contacts for folks who have just presented. We'll make sure that those go up on the NIHB website. Some of those names are already into the chat box right now. So if you want to see them right now, you can scroll up into the chat box. The first question that we have around the content is, will tribes be receiving funding to purchase necessary equipment to store vaccines at the right temperature? And a related question around, are dry ice suppliers being put on standby? Are they aware of the no price gouging laws? And then we did get another question around just generally funding for our providers to administer the vaccine, and are there funding streams available for our providers to administer the vaccine? So I will pause there and receive the answers from IHS.
This is Admiral Frazier. Good questions and several related questions. There is no charge for the vaccines itself, and as far as funds for administering, what we're really counting on is programs to look at their existing funding resources, and as far as I'm aware, there's not specific dollars assigned for COVID vaccine 19 administration at this point in time. So really programs, you're looking at how you're currently carrying on your existing vaccine administration activities. There will not be any charge for the COVID-19 vaccines themselves. And that's about as much information as I have right now. There are others on the call who may be able to provide additional information that I'm not aware of. We're more focused on the vaccine planning activities. So I'd put that out there if there are any other individuals, either on the IHS side or CDC side, that would have any additional information.
Thank you, Rear Admiral. And I do have another question. So we do have CDC on the line, and they have some presentations to share with us. So we will definitely get over to some of the questions that they could answer for us in just a few moments here. But I want to go through some of these other questions in the chat box. So we have a question: how do we ensure inventory for the second dose, since we might not be able to guarantee that follow-on vaccine will be from the same manufacturer?
This is Commander Fretland. I can take that question. So as Commander Holly Van Loo had mentioned, Operation Warp Speed and CDC are looking at holding back, especially in the limited early phase 1, holding back vaccine for that potential phase 2. So that is being discussed and evaluated right now. As we move into later phases, one strategy would be that as you receive allocation of vaccine, and I'm talking about the non-ultra cold, so frozen and refrigerated, that you would keep that half, you would allocate and vaccinate half, and then you would restore the other half for that second dose, ensuring that you have that same brand on hand for the second dose. But for early phase, for ultra cold, that is being considered at CDC and Operation Warp Speed of how to hold back at an Operation Warp Speed level that second dose to ensure that the same brand is available for the second dose for those who are vaccinated.
Thank you. And I have another question here. Will state and IHS be delivering the same vaccine? In other words, if 2 different types of vaccines are approved, will tribes have access to each if you make a select IHS or state for distribution?
This is Commander Kaylee Fretland again. I'll take that one. So the allocation is going to be across all jurisdictions, IHS included. So if the ultra cold from Pfizer is the first vaccine that gets the EUA and is approved, that's going to be allocated across to all jurisdictions. If it's the frozen, it's the Moderna vaccine, again, allocated to all jurisdictions. If it's a mix of both, it'll be allocated equally based on percentages to all jurisdictions. So we anticipate that as states and IHS get that allocation, especially in these early phases, it's likely going to be for the same vaccine. Now, states could choose to maybe not go with ultra cold or a particular vaccine. That is up to that state, and we can't determine that information. But we can say allocation should be equitably to all jurisdictions across the board as they're approved and as they come out.
Thank you. And to Kelsey, do we have some of our questions in the chat box queued up and folks unmuted?
We have Chief Cook.
Thank you.
I think that it's been informative. There's still quite a few questions. Wanted to thank you for your time, and wish that we could have more sessions to impart some of this information. I think that tribes feel intensely pressured, and the situations that we have at home that leadership and other administrative folks are dealing with is immense at this time. I think that some of your deadlines have been unrealistic, and so though tribes have had to make decisions as of today that were posed to questions that were posed to them a week ago, I'm wondering if tribes will be held to those decisions that they're making now under this intense pressure, if at a later time it's determined that the decision that they made today maybe isn't going to suit them as well, or to give tribes time to decide, because there's some tribes that want to use the state and IHS, and we're under the assumption that now they have to choose one or the other. So are they going to be given additional time to do that, to make those decisions as they get more information? Because the information, the bulk of what we're hearing today wasn't available prior. That's all.
This is Commander Holly Van Loo. Sorry. Thank you, Chief Cook. Those are well understood and recognized comments. Many of the deadlines are really not set. we're really set because of the standard that all the other states are using, and the CDC and Operation Warp Speed is dictating. So we are working obscene hours trying to do our best, and sometimes things change within minutes. And so we really appreciate your flexibility and understanding, and we are being asked, as you are, to make decisions sometimes with little information. So we really appreciate all your work, and I'm hoping maybe our CDC folks can talk a little bit more about this next component about distribution source, IHS versus CDC.
And Chief Cook, this is Admiral Fraser too. I really do want to acknowledge your comments and add on to Commander Van Loo's comments. You know, we understand there is intense pressure and what you're feeling, and thank you for conveying that, and for all the tribal leadership that are feeling the same. You know, we feel that pressure too, and we're doing our utmost to get information out as quickly as we can. And posting that information to the IHS website to help inform all of our partners as to the IHS activities. And we'll continue to work extremely hard to make that happen. So thank you for you know, sharing that comment with us.
Thank you.
This is Almia Matnock from CDC, and thank you as well, Chief Cook. We're also happy to be available as much as possible to try and answer questions in more forums like this or others. I think that it sounds like very much still a need, and we're here to provide as much information as we have. But we also acknowledge the reality that not all of the information is known, and some decisions are having to be made without all information. And I think we are all in that reality right now, and it's very difficult. It's extremely hard to make plans when you don't know the details, but that is the situation. I would like to speak to your question about, you know, the two places which from which to access vaccine, either through IHS or what is termed in the playbook jurisdictions, but what we really mean by that is the routine immunization programs that are in all of the states and some large cities and territories. And that is there in order to leverage existing vaccine distribution process and clinical infrastructure. And I think that that is in some ways an advantage of the situation, that there is this ITU network that can be used to help ensure vaccine access. And there's a lot of complexities of logistics and reporting that really don't favor dual enrollment with both IHS or state and local immunization distribution models. But I think everybody's concern is that there won't be equitable access for tribes, and that's happened in the past, and we acknowledge that, and that's why we want to ensure that we get things set up in the best way possible now. And so really talking through what those details are for different tribes, for different ITUs, I think is what we're trying to do through the consultation process, but as we move forward and get closer to vaccine being available. So I just wanted to say that. I know we have some other comments, but I felt it was important to answer your question. Over.
Okay, thank you very much for that response. And I also want to acknowledge that we have Devin Delro on the line, and he just let me know that he has a little bit of information that also addresses Chief Cook's question. Devin, can you unmute yourself? Devin, we don't hear you yet. Okay, so I think that there might be a technical difficulty with Devin's line. So I think we have another, we have Councilman Lewis in queue. Kelsey, can you make sure that he's off mute?
Can you hear me okay, Carolyn?
Yes, we can.
Hello, thank you for all being here and being part of this important discussion. I did have a question, comment, so to speak, and that tribes must be allowed to change their selections on the vaccine distribution. If the state fails to distribute vaccine to the tribe and the tribe then goes to IHS, IHS must provide vaccine to the tribe in honor of its trust responsibility. We need assurances that tribes can change their selection. And can you confirm that tribes do have that ability? We look at past history, tribes were denied, specifically around H1N1, and that raises a lot of concern and brings a lot of trauma back to these discussions when the state and the federal agencies fail to meet its trust responsibility. So look for being able to confirm that question and comment. Thank you.
Good afternoon, Mr. Lewis. This is Admiral Chris Buchanan. Just wanted to first, can you hear me?
Yes.
We can hear you.
Thanks. I struggle with Zoom, WebEx, Skype. I'm not sure what systems I'm on most of the time, but definitely hear your concerns, Mr. Lewis. And I know those are discussions that we continue to amplify of the tribe's concerns. Right now, we're just familiar with the one or the other discussions, one, choose the state or choose IHS, but I and myself, Admiral Wiaki, will continue to amplify those concerns as we have discussions with leadership going forward.
Thank you, Rear Admiral Buchanan. I think that Devin is able to speak now. Devin? Okay, I think if you're trying to speak, you are still on mute.
Yeah, good afternoon. This is Governor Michael Chavia from Santa Clara Pueblo here in New Mexico. I'd like to thank you all for hosting this call. For New Mexico, there are a number of pueblos that are still considered direct service tribes. And so that was a confusion we were having regarding those agreements. But now I hear that if we're a direct service tribe, that CDC will send that for us, as an example, to the Santa Fe Service Unit, which will sign that agreement. I think the confusion was, as you said, tribal governments. There are some that are still direct service, some are Title I, some are Title V self-governance programs. And so that's very essential to have the tribes understand that, because it's not going to be Santa Clara to sign that agreement. It'd be the Santa Fe Service Unit as a direct service provider to sign that agreement for my Pueblo. And I know we had a deadline by today at 2 o'clock to submit yes or no. We are going with the IHS. So Santa Clara, through our tribal council, did agree to go with in-house service at this time. But I believe there's other critical elements to really understand, is that there's a limited supply. Again, if we go with the state or the in-house service, and not knowing exactly what those limitations are going to be, also makes it difficult for logistical purposes. I know we had a number of calls with Dr. Thomas here in New Mexico. My concerns were, are there enough service providers to monitor these patients once they get the vaccine on a daily basis to determine if there's any negative health impacts that might be associated. And so that's also important, and why I keep pushing for the Commission Corps staff to help our service unit here in New Mexico and Santa Fe, so that they're not overstressed resource-wise. And because they'd be the one to have those type of facilities for that cold storage or ultra cold storage, it's not going to be my Pueblo because we don't have the capability nursing wise or staffing wise to distribute, or how would you say, administer that vaccine. So we got to rely on our service unit to provide all that services to the Pueblo going forward. And so it is critical of why we're being rushed to make that determination. And I hear that you have to submit by next week, which is November what did you say, the 5th or 6th? But again, we're asked to submit information today. And then I understand the priority population is going to be the healthcare workers. But again, in our respective communities, we have CHRs, first responders, law enforcement, teachers, tribal government officials, leadership, our EOC team, our transportation. So there's a lot of other priority essential workers, which I consider frontline workers. So those are the numbers that I'm going to be presenting to Dr. Thomas going forward for Santa Clara. But again, we're also told out of that number that we submit, which ones are going to volunteer to get an accurate count to ordering that vaccine. And then the consent form to sign off. So there's still a lot of questions to be asked on the possible next steps to get the accurate numbers, which you have put in your presentation earlier. And then also hearing that there's not really no final word on when the vaccine is going to be available to roll out. December, I heard maybe not till April next year. So all this is very critical. How do we plan logistical wise so that we can inform our community phase 2 and phase 3 to come about going forward. And so, but appreciate the information that's being presented. I know that the beneficiaries and the non-beneficiaries are also important because we have mixed marriages from Indian to non-native. And as long as we can provide them and be considered as eligible to receive that, that's critical. And then the service unit would have the high risk individuals. Because of HIPAA, I don't have that information to say, well, this individual has obesity or type 2 diabetic, because I think those are the priorities they're also looking at. So I have to rely on the service unit to provide that information to make sure those individuals are covered. Then again, we have tribal members that have their private healthcare insurance. So it's really up to them to either go to IHS or the state. And that's another difficult issue. How do we deal with that? And not making sure they're not left out. So there's still a lot of questions, but I'll submit a written comment to that. What did you say? Consultation.gov with additional questions I may have. But thank you for the time today.
Governor Chavarria, this is Chris Buchanan, and just wanted to respond quickly to the comment. Appreciate your leadership. Those are some great questions and some great comments. And I know that as we've been talking through, there's been lots of concerns and, some great information that's been presented from the folks on this call, CDC's input and the conversations that we've had at the department. And I see Devin on the line here, and I know that he's been working with HHS and some breaking news. So wanted to see if he was actually able to address his audio challenges.
All right, let's try this again. Can you hear me?
Devin, we can hear you, but you are echoing pretty badly.
Perhaps while Devin tries to connect again, this is Almia Matnock. I could just speak to one of your points, Governor Chavarria, and thank you again for your comments and ideas and questions. But I think that while we are all waiting on many moving pieces for when this vaccine actually comes about, and it's not so much a matter of exact timing, but rather of events that have to take place in order for the trials to come to a certain point that information can be analyzed and can be reviewed, and then the FDA potentially putting out an EUA. So those are things that don't necessarily have a specific timeline, but right now the date that we're working towards is November 15th. And I think that the points that Commander Fretland made in her presentation, as well as others with IHS, and thank you guys for carrying the majority of the information that was said today, but is to bring up the idea that not making a decision now about the point at which vaccine is accessed does not mean that at a future date vaccine cannot be accessed. It is simply that it may delay all the pieces that need to get in place so far out that the result could be that initially the facility or tribe may not be able to access vaccine when it first comes about. So I think that we really wanted to make that point. I think, the deadline was heard as sort of an ultimatum, but it's not that. It's so that we have enough time to get the pieces in place that IHS spoke to today before any vaccine is available, so that that very initial and early access to vaccine is available for tribal nations. Over.
This is Devin. Can you hear me now?
Yep.
Yes.
All right. So thank you. My name, and I really apologize for the audio troubles. My name is Devin Delro. I'm with the Office of Intergovernmental and External Affairs in the Office of the Secretary at the Department of Health and Human Services. I'm very excited to share with you some very exciting news in response to some of the concerns we've heard from tribes across the country. Operation Warp Speed has approved a 1-week extension for tribes to determine their vaccine distribution preference. That means that tribes with healthcare facilities now have until November 6th to contact IHS if they would like to be included in IHS's distribution, or contact their state health authority if they want to be included in the state distribution. We know that this is still a tight deadline, but it is absolutely critical that this information be received by November 6th in order to ensure equitable COVID-19 vaccine access for tribes as soon as a vaccine is available. And please keep in mind that as additional vaccine candidates are approved and manufacturing is increased, there may be additional flexibilities in vaccine distribution streams. But for the time being, the information you provide by November 6th is essential for immediate access to a vaccine when supply may be limited. We will send out a follow-up to our email last night clarifying the new deadline, and we greatly appreciate all the recommendations and feedback that tribes have shared throughout the vaccine planning process. And we look forward to continued partnership and collaboration. Thank you.
Devin, this is Governor Chavia again. Thank you for that information. And yes, it'd be important to send that out to Dr. Thomas, the area director here at in New Mexico, so that we share that with Dwayne, our CEO at the Santa Fe Service Unit, to put that out so that they can send that information to all the tribes, pueblos, and nations here in New Mexico. I know it's another week, but it's very critical because as we're talking about, the plan's still in draft form, and it sounds like there still needs to be additional information to have that consultation to really get to the final document moving forward. And we are different from the state because the Indian Health Service, HHS, is our trustee, our federal trustee. And so that's very critical of how you advocate for us as pueblos, tribes, and nations to the best of our ability moving forward. It is unfortunate we're in this situation of COVID, and yes, we need a treatment. And so I'm not too sure that Recidivir, is that what it's called, is been provided as treatment option to the Albuquerque area, to any IHS facilities in case we need to provide treatment to our patients. But like right now, the service unit is basically a clinic, and in order to get specialty type of care, you're referred out to other New Mexico private facilities. And so making sure the PRC is also going to cover such costs for that treatment if it's available. That's very important as a next step as well. But again, thank you all, and I'll submit my comments for the record.
Great, thank you. We will make sure this information is shared widely later this evening.
Thank you, Devin. This is Carolyn Hornbuckle from the National Indian Health Board again, and I believe that Chief Bill may have had to leave us. I know that we are at the end of our time here, but we would like to invite our panelists to stay with us a bit longer. We have a lot of folks who have joined us for this call, and we know that we haven't gotten to all the questions yet. So if you are able to stay with us, please, oh, I see you, Chief Bill.
Yes, Caroline. Yeah, if they're going to stay after the 5 o'clock deal, I'm going to have to drive back to Valdez, and it's snowing pretty good here in Fairbanks, and that's a 350-mile drive back, and I already slipped and fell on the ice out here this morning. So I would appreciate it if you would help finish up if they want to stay on the line, because there's lots of good questions that needs to, and if the federal people will stay and answer them, that would be very much appreciated. And thank you.
Thank you so much, Chief Bill. Please drive safe. So I know that we also have some CDC folks with us today, and you've heard from Almea, but I know that there may be a few things that CDC would like to share in update. So I'd like to turn the floor over to CDC for some very, very brief comments, and then we'll go to the rest of the questions. We have a few more in the chat box, and then I know we have other folks that have asked to get unmuted. So if I can open the floor to CDC, and I can give you, a few moments to share your updates. Thank you.
Hi, good afternoon to everybody. My name is David Fitter, and I'm one of the co-leads for the Vaccine Task Force at CDC. I just wanted to say thank you for inviting us to this forum. It is, we really appreciate it, and I think these are great opportunities to hear from people and also to share information. I do want to underscore that we are absolutely hearing you. I think that, some of the conversation today, you've seen some of these answers. I'll keep my comments brief. I think one of the aspects I really wanted to underscore was the overarching objectives for the COVID-19 vaccination program. And maybe you have heard this, maybe not, but certainly it's to ensure safety and effectiveness of COVID-19 vaccines. It's to reduce mortality, morbidity, and incidence of COVID-19 disease. It's to help minimize the disruption to society and economy, including maintaining healthcare capacity. And also it's to ensure equity in vaccine allocation and distribution. All of this goes into some of the implementation planning as well, from ordering to distribution, reporting, and monitoring. Our goals are to support jurisdictions, to support tribal nations and other partners in this process. We've been working very closely with Operation Warp Speed, with our colleagues in Indian Health Services, and also in discussions with other federal partners and with the tribal nations as well, with the hope of sort of arriving at this. I'll just jump ahead. I think most people have discussed a lot of what's been going on, from Admiral Fraser to our other colleagues at IHS. I think the playbook is providing a lot of this information, and an updated copy of the playbook will be coming out shortly that addresses some of these issues as well. Ultimately, the process is moving at a quick pace, but I do want to ensure that you sort of touch on those overarching objectives again: safe, effective, and equity, sort of equitable access to everybody. These are the goals that we're looking for, I think, together. And then we really do recognize the importance of information and decision-making processes, and we want to ensure that we are trying to make information available as soon as it is ready. Again, I think we're all working together. This is a huge lift But I do see that we're getting to where we need to be, and certainly making it to the November 15th date as we, begin the phase 1 processes. We are going to get more information as this process continues, and we are putting together plans that don't have every piece of information we would want, but we do want to ensure that we're working together with the pieces of information that we have to ensure that there is equitable access to this a safe and effective vaccine. I'll stop there. I think Dr. Matt Nock is also on to address some other points. Thanks.
Thank you. We had prepared a few slides, but I think probably given the time and what has already been said, I will just cover a few more highlights from those that we wanted to mention today. So again, thank you all for being here. Thank you to NIHB for hosting this, and to IHS for carrying the majority of the presentation today. I think I mentioned already the need for, or the desire to leverage existing systems in order to ensure good access to vaccine, and therefore the need to choose between the two pathway options to access vaccine. I think it has been said, but maybe just to summarize at this point, that there are several steps that need to be in place in order to access vaccine, as outlined in the IHS presentation today. But to summarize, those involve signing a provider agreement, connecting to the respective data systems, accessing storage and cold chain capacity. And there is work being done there around ensuring that rural sites can access an ultra cold vaccine the same way that sites that have -80 freezers can, probably using the actual shipping container that the vaccine comes in. And then it's ensuring that staff are trained on storage, handling, and administration and documentation procedures, and being ready to order, receive, store, administer, and report on COVID-19 vaccine by day 1 of vaccine access. And right now, that date that we're working towards is November 15th. So I think just to say again that there are some who have made these decisions already, but for those out there where the decision is still pending, or there's still question about a decision that has been made, reaching out to the jurisdictional immunization program and/or IHS area offices to better understand these details is what would be needed. We are also happy to present in other forums to smaller groups if that is of use and would be helpful. And that a delayed decision could result in delays in receiving initial COVID-19 vaccine, but does not mean that vaccine will never become available or will not be available. So I think those were the highlights of what we had included in the presentation, and are available to stay on the line if there are further questions. Thank you.
Thank you, Dr. Matnock. We do have some other questions on the line, and we have some folks who have asked to be unmuted. I think that Kelsey has indicated we have a couple of folks that are queued up and ready to go.
Yes, and right now we have Sam Moose.
Yeah, can you hear me?
We can hear you, Sam.
Thank you very much. Sam Moose with Fond du Lac Band Lake Spirit, Chippewa, Minnesota. Thank you for the presentation, the information to NIHB and to all our federal partners that are on the call. As you heard from a number of tribes, there's definitely a lot more questions than answers that we had. So the information that was provided is definitely critical in helping us make a decision about where we go with regards to vaccines. And like was said earlier, Indian Health Services has a unique relationship with tribes that we want to make sure is definitely a main point of the conversation. And I did see a couple of questions that were also in the chat that were similar to the ones I had with regards to just the methodology for distribution that currently is being presented under the 1.7 million number that was part of the earlier presentation from Indian Health Services on distribution. That methodology is a little bit different than what the state, we just had a meeting with the state of Minnesota with regards to vaccines and making a choice. So definitely very glad to hear the extension that was presented by DHHS. That's really good to hear. There's just a lot of pieces that we're unsure of. The 24-hour reporting period that was identified in that presentation too. Many of our tribes are not part of the RPMS system, so we really want to make sure that we're compliant with those pieces and want to try to identify how those work. And then just regard with distribution coordination with the 5-day window of the vaccine that's I think the term is ultra frozen or something like that. That's going to take incredible coordination on our part with regards to the tribe. So we know that in past vaccines that they come in, they just show up. We identify that they're supposed to be here on a given time, and then we don't receive those, and those may be from McKesson or other places that tribes get those, and they just end up showing up. So we want to make sure that those pieces are all definitely laid out and in place, especially when we need to make a decision on whether we go with Indian Health Services or the state, and make sure that Indian country gets its doses needed to provide vaccination when it does come for our first round of essential workers and healthcare workers. So those are probably our biggest concerns. So I do hear those on the thing. Won't take up any more time. Just those are pieces we really need more information on. And glad to hear we have 6 more days. I will definitely be getting on the phone to give Commissioner Malcolm a call within the state and see if that is similar with them. I'm assuming it is. So, Miigwech.
Thank you, Director Moose. Do we have someone from IHS or CDC that would like to respond?
Yeah, Carolyn, this is Chris. I just wanted to respond a bit to the, and great to hear Mr. Moose's voice on the line. And I think I heard some finance questions in there. So we can take those questions and provide some additional answers offline. I know I apologize for not having our finance folks on the line to answer some of those specifics, but we'll take that back and provide you a response.
Thank you, Rear Admiral. And I just want to mention that National Indian Health Board, we recognize that there are a lot of questions and that we have a lot of folks on the line, and I fear that we did not slate enough time for this, but we will, as an organization, open up an additional platform, perhaps something along the lines of a vaccine summit so that we can really do some of the deep dives and get everyone on the line so all of these various questions can get answered. As has been pointed out, there's so many questions and more questions than answers, and we really do need to have some time to get through these questions. But we appreciate, every one of you being on the line and sharing the information that you do have. I think that we have Chairwoman up next. Are you unmuted?
I believe so. Can you hear me?
We can hear you.
Excellent. Well, thank you very much, Carolyn. And also thank you to National Indian Health Board, IHS and CDC for hosting this and providing the information for us. I just want to note there are so many really wonderful questions in the chat box, and that I'm probably redundant to some of them, but I'll just keep it to a couple of points, namely with the tribal access through the Indian Health Services. I'm trying to figure out or trying to find out how much the Indian Health Services is going to be allocated in total, as well as because the tribes are determining their own priority on how to disseminate their allocation, who is going to be deciding on the amounts that an individual tribe is requesting, and who is deciding on the amounts that Indian Health Services is going to be allocated. My second question or point is with regard to the data. And if members in our situation, I'm sure most of you know, we have members that live on the island, which would probably come and receive any vaccinations through us on the island. However, we also have tribal members that live on the mainland, which we also administer to, and tribal members that live in many other parts of the state and region and country, like most tribes. And we do provide services to those tribal members in different varying capacities. And what I'm concerned about is like what happened with the testing and the test results, that if our tribal members seek or receive vaccinations or through another mechanisms, whether it's through the state or whether it's the individual or private insurance, as one of the previous callers mentioned, does that and will that impact our population numbers of our service population and or future allocations for us with a second round or additional vaccines in those doses? And I'll leave it at that because I know so many people have other questions to ask, but thank you.
Ma'am, this is Commander Kaylee Fretland. I'm going to take the first one of your questions as far as the distribution goes. And I think it's easiest if I give an example of how the allocation is going to work. So CDC and Operation Warp Speed, if the first batch of vaccines that comes out is X amount, they're going to generate a percentage across all jurisdictions. We don't know what that's going to be yet. We have not been told. They're still working on that because they still need all of our numbers. So that determination will be made. But we have full confidence from Operation Warp Speed and CDC that IHS will get their share of allocation, the same as all the states. Once IHS gets that allocation, so I'm going to use our healthcare personnel, and I'm going to take that 55,000 number that I shared earlier on the slide. If IHS, that first batch that comes out, if there's only 5,500, that is 10% of what we need for all of our healthcare personnel. Every site that is coordinating vaccine distribution with IHS would then be given that 10% allocation across the board. So that's how we're looking at doing our allocation in an equitable and fair way. We recognize that our patient populations overall are at high risk, and we don't know how that's going to play into the overall CDC and Operation Warp Speed allocation strategy. But once we get it to IHS, as we're looking at healthcare personnel, long-term care, elders, those with chronic disease, essential workers, we're going to be looking at that overall percentage, and whatever IHS gets allocated in that percentage, that's going to be the allocation that's going to be shared amongst all of the sites that are coordinating vaccine distribution through IHS. So I hope that helps answer your first question.
Yeah, but I just would like to know then, that count that you're basing it on, is that count going to be submitted by the tribes based upon our determination of who we've determined to be the most vulnerable of our populations, whether it's frontline, elders, health compromised, whatever our determinants are as we decided as tribal nations, and we'll be submitting those numbers. And I'm hoping, and I say this with all due respect to every other agency, but we've just experienced recently, while we go through these exercises of making these determinations and submitting critical information for number counts for what we expect are going to be used in the calculations, that the numbers that we as tribes submit to the Indian Health Services will be the numbers those 10% are based upon, and not just dropping back into some antiquated or probably incorrect data that has been collected over the years.
So you're absolutely right. We are using the numbers that were submitted by the tribes with the pre-planning tool. So we want to value those numbers. We reached out, we asked you to do a lot of work to try to get those numbers to us, and that is the numbers that we are using.
Okay.
And as to your second question, you asked about those members, those band members or tribal members that are not living within your maybe physical area. Maybe they're in different states or different locations. The states, when Operation Warp Speed is breaking down their populations, they're looking at various census data and additional data for everyone within that state. And that's what the state numbers are generally being based off of as a whole. So if those band members are in different locations, they are likely being included in the state's numbers. As far as access to vaccines, if you feel that those band members routinely receive healthcare at your facilities or your locations, they should be included in your numbers. But if they generally receive healthcare at other locations, they are already generally going to be included in the state numbers. And I think it's also important to remember that the US government has contracted for enough vaccines for 330 million people. That's 660 million vaccines. So over the course of all the vaccine manufacturing, it is anticipated that every American is going to have an opportunity to receive a vaccine if he or she wants to receive a vaccine. We may have extra vaccines left after the end because we haven't had as much uptake as we anticipated. But overall, I think all agencies, all jurisdictions, our goal is to ensure full allocation for to meet your needs for your tribal populations.
Thank you. It would be nice if the states were to seek the actual residents of a tribe from the tribes and then use the census data to backfill that, because as we all know, the United States Census data with relative to accurate tribal counts has always been grossly underrepresented. So I just want to make sure that that is clear when we are looking at those things, because every time they drop back on census data, it harms the tribes and overwhelmingly disproportionately to any other group of citizens. So thank you very much for your answers.
Thank you very much. And I think we have time. We'll go all the way up to the half hour, and we have a few more minutes to take some questions. But we did have one follow-up question for Ms. Fretland. If a tribe does not submit that information, how is the tribe's numbers, how are those numbers getting recorded? Is there some kind of a default that will be kind of kicking in?
Okay, that's a great question. So we are actively reaching out to all tribes who did not complete the pre-planning or left blanks in that, or where there were gaps. Most had completed, but we did have several blanks. And so we've been actively working with the area offices to reach out to those tribes who potentially had blanks, because they may have been satellite clinics that were partnered with a parent hospital or parent clinic. We want to make sure that every tribe has the opportunity to submit that information. We do have some estimated calculators that if we do not receive that, or if a tribe has any request for assistance in calculating those numbers, we've got some ability to help with that from either an area level or at a vaccine task force level. So we'd encourage you to work to reach out to us if you do want assistance with that. We want to ensure that everyone has the ability to determine their own populations, and we don't have to use an estimated population. And I do see just one other question related to that. If a tribe submits data on the number of vaccines they need and then realize there was a mistake in the data that they need more than submitted, how will they go about getting the right amount if numbers needed to be changed? If that's the case, if the tribes misunderstood or didn't have full information, or the right person wasn't there that they needed to get the information and they just had to give an estimate, please reach out to your area vaccine point of contact. Each area has an area vaccine point of contact, and work with them to get those numbers updated if you need to. But we are turning these numbers over to Operation Warp Speed in a very pretty quick time. And so we'd encourage you to work with your area vaccine point of contacts as soon as you can to go over those numbers, or if there's any adjustments that need to be made. And we recognize again that we want to make sure this is fair and equitable. Our goal is to provide 100% allocation to all of our brothers and sisters out there, all of our tribal members, as rapid, timely, and fair process as we possibly can.
Thank you. And I think we have another question in the chat box, and then I'm going to let Kelsey unmute some folks. But there's a question in the chat box. If you get vaccines from the state, will there be any duplicate reporting to both state and federal? It sounded like possibly for adverse events.
This is Holly. I can speak on that. Holly Van Loo from Indian Health Service. I wanted to mention that with this, if you were to receive, perhaps you have a clinic that has two different components, and one is tribally run or urban program, and one is a federal site or something, and you end up having an IHS allocation, and then you somehow end up with a state allocation as well. The reporting pathways are just two separate processes and two completely separate pathways. Not that it couldn't be done, it would just be highly complex to account for every one of those doses in two different pathways for documentation. So IHS has a wholly different process for reporting inventory and ordering, which is completely different than the state or how they're ordering, monitoring temperatures, inventory, things like that, as well as the data flows are different with how you would report doses and report those within that 24-hour time period. So as a person who runs a giant site with a ton of vaccinations given yearly or even daily, it would be overwhelming to try to monitor both data flows to ensure that the vaccinations are being accounted for because they're asking for dose level accountability, much like the Vaccine for Children program that many of our sites are familiar with. So just that, I just want to point the complexity of the two different pathways. Over.
Thank you for that. I think that we have Vernay queued up.
Thank you. Can you hear me?
We can hear you.
Okay, great. Thank you. I'll try to speak fast. Rear Admiral Buchanan, Devon, agency partners, and NIHB, we want to express our gratitude. We know that so many of you, just like so many of our folks, have been working around the clock on this, and we appreciate all that effort. We are very thankful for the extension to November 6th to make the determination. It is certainly helpful since we just received some of the materials, and these are very valued materials, and the presentation itself as well. We do concur that we have the sovereign right to self-determine our priority populations, and so I just had to put that on the record. And I just wanted to respond very quickly. We can appreciate that there are capacity limitations to dual enrollment, particularly for perhaps this first batch. But I wanted to state that tribal health systems are complex, and they exist across multitude of jurisdictions, including tribal, state, local, and federal. Many tribes operate across state lines, or in our case, our programs are the only programs for the entire community. And so we are ready to work within both the IHS and state systems to deliver care in a manner which is best for the communities and not duplicative. So we are ready to take that on and jump into that. We strongly believe that we need to be able to have that dual enrollment status. And we know that this is an iterative process. We know that Operation Warp Speed is moving. We don't expect this is going to go away right away. So as we move further, we need to have flexible and nimble systems to allow the mobilization and distribution of safe and effective COVID-19 vaccine. So I just want to thank you for allowing me to put that on the record. And I hope that the agencies, I hope Operation Warp Speed will take that into consideration. Thank you.
Thank you, Vernay. Do we have one of our agency partners that would like to respond?
Almia Matnack. I'm happy to respond to that, and thank you for bringing that up. We recognize that this is a very complex landscape and that we also want to keep open or ensure a flexible and nimble system to make sure that when vaccine comes about, because we all know that even though we're in planning, the reality of the situation once it's actually implemented will likely be different than anything we could have planned for, although we're trying to do our best to plan for what we think will happen. I just wanted to acknowledge that definitely within any tribal nation, especially ones that are served by multiple facilities, that it may make most sense for one facility to access vaccine through the state and another facility to access it through IHS. And I don't think any issue with that. I think where we foresee potential issues, although are very much open to a dialogue around this, is with one facility accessing vaccine from both the state and IHS. As you can see, it's complex, and figuring out how to work in these numbers, ensure that it's equitable for everybody is difficult, and would, I think, be made more so by that, but welcome your thoughts on that. And the last thing I wanted to say on that point is that if a tribe accesses vaccine, for example, through IHS, but the state is making outreach about, particular campaigns of vaccine, for example, like pods that are a model that have been suggested and used in the past, that there's no reason that a tribe couldn't partner with the state around those. So I think, it is a complex landscape, and it's very much different for each tribe and each state and the presence of IHS there. So figuring out what will work best and ensuring that the system is set up that way. I don't think there's any intention to try and limit it. It's just to try and make it successful. Over.
Thank you
Dr.
so much. And we
Matnock.
certainly do. We certainly do appreciate that. And I just wanted to add very quickly that the immunization program that we have here in Alaska has decades of experience and a combination of working with the area office, the states, and definitely in looking at ways to distribute vaccine throughout the communities in some of the most harshest and most remote, and where 80% of our communities are off the road system. We definitely need that flexibility, that nimble, and being able to look at systems that have already been in place. So thank you.
Thank you. And this is Carolyn Hornbuckle again from the National Indian Health Board. I know that we did not get to all the questions. I see Libby had a question, Melinda, Sunny. So I do acknowledge that we have some additional questions in the chat box. And for those of you in the audience, you may have questions that you wanted to ask. And we want to, at the National Indian Health Board, make sure all of those questions actually are directed to our federal partners and that we get you back some answers. So I mentioned before that we are going to look to having another forum where we can have a little bit more time and get some more of these questions on the table and answered. So please do look out for that notice. We will make sure that we get that out to everyone who joined us today. And I also just want to pledge to you that if you've put a question into the chat box, we are going to follow up and get those questions answered. And all of these materials will be posted on the National Indian Health Board website. I want to thank all of our panelists for their time, and I especially want to thank them for staying on with us later than expected. And all of our audience members, we really appreciate your time. This is such an important topic, and we want to make sure that this goes right and that our people are protected. So thank you for all that you are doing in Indian country. And we will see you around the bend. And please do check the website for these materials, and please do reach out to NIHB. All of our staff are available to help forward your questions, gather answers. find materials for you. This is what we are wanting to do with all of you in Indian country. Also have a safe and happy Halloween. Thank you very much, everyone.